Hi, Dr. Brazier here. Welcome to this presentation on trauma-focused CBT, or Tf-Cbt for short. Let's jump right in. Tf-Cbt is an evidence-based treatment that has been internationally tested in the US, in Europe, and in Africa. It's a short-term treatment. It typically lasts only about 8 to 32 weeks. So this timeline can be further broken down depending upon whether the trauma that the child experienced was a single incident trauma, in which case treatment tends to fall somewhere between 8 and 24 weeks, or a compound or complex trauma, in which case treatment tends to last longer, right? Somewhere in the 24 to 32 week range. Tf-Cbt is a treatment for children and adolescents, so between ages 3 and 18 years old, and their primary caregiver or another protective adult. Tf-Cbt has been proven to improve PTSD symptoms, depression, anxiety, and behavioral problems in younger clients. So Tf-Cbt prepares a family for focused work on the trauma narrative using 4 strategies. And although they don't explicitly engage with Dr. Judith Herman's 3-stage model of trauma treatment that you know, we can envision how these strategies fit into stage 1, safety and stabilization. So first, providers offer psychoeducation and parenting skills to the caregiver. They educate caregivers about trauma, about its effects. They normalize the behaviors and coping strategies that the young person is demonstrating, and they begin working on combating parental shame and guilt. They help the caregiver have language around the difference between good secrets versus bad secrets, so that then that caregiver can help the child understand this concept moving forward. The second preparation strategy of Tf-Cbt is teaching the child relaxation techniques. The therapist leads the child through developmentally appropriate grounding and relaxation and mindfulness exercises. Then third, Tf-Cbt therapists teach the child affect modulation skills. So the young client begins talking about their feelings, and language is given about different emotions, including how they define different emotions. And an emotional vocabulary is built so that the child can now communicate their feelings not only to their counselor, but also to caregivers and other safe adults. And then fourth, the counselor teaches the young client cognitive coping skills. The child learns to distinguish between thoughts, so for example, a thought like, this is hard, and feelings, so for example, sad, angry, helpless, and behaviors, so for example, avoidance versus facing something head on. Developmentally appropriate strategies are used to help the child identify automatic thoughts, helpful versus unhelpful coping strategies, and cognitive distortions. And again, all of this is preparation work for what lies ahead, which is working through developmentally appropriate exposure-based methods to desensitize the young survivor to the trauma that they've experienced. So once the child is properly prepared, again, what we might consider ready to progress to stage 2 trauma treatment, then the counselor turns the work toward the trauma narrative, toward processing the actual traumatic event. And clients are going to tell and retell the story of the traumatic event or events with increasing detail. So this is gradual exposure. They start from the beginning and they slowly work toward the hot spots of the traumatic memory. Older children can be helped to compile sort of a book of the traumatic memory or memories with both written accounts, maybe some drawn images. Other alternatives can include sand tray, use of playroom toys, etc., to tell the story with increasingly detailed account. So this work creates a sort of an in vivo desensitization experience, and the client is increasingly able to remain within their own window of tolerance while recounting the trauma, which facilitates a sense of mastery over that trauma. So during this stage, there are conjoint parent-child sessions that are also taking place. And in those sessions, the child is going to be able to share their thoughts and feelings associated with the traumatic experience with the caregiver. And this can lead to confidence building in the child, and it can help facilitate trust and belonging if it's done within the safety of a healthy relationship. And the counselor is there then to guide this connective process. And additionally, some work is done on enhancing safety and social skills. The child is helped to identify safe people and places, which they may have never been helped to distinguish before. The counselor incorporates exercises designed toward empowerment, including facilitating talk about body ownership. The child is taught how to advocate for themselves by asking for help when help is needed. And the intention behind this work is to help prevent future trauma by giving the child a voice and then teaching them how to use their voice. So here are the Tf-Cbt components in a nutshell. They can be recalled using the acronym PRACTICE. So P stands for psychoeducation and parenting skills, discussing and teaching about child abuse in general and the typical emotional and behavioral reactions to sexual abuse, as well as to skills training for parents in positive parenting, child behavior management strategies, and effective communication. R stands for relaxation techniques, teaching relaxation methods like focused breathing, progressive muscle relaxation, and visual guided imagery, which might benefit the parent as well. And then A stands for affective expression and regulation. So helping the child and the parent manage their emotional reactions to triggers of reminders of the abuse, to improve their ability to identify and express their own feelings, and to participate in sort of self-soothing activities. Then C stands for cognitive coping and processing, helping the child and parent understand the connection between thoughts, feelings, and behaviors, and exploring and correcting inaccurate and or unhelpful attributions related to even everyday events. T stands for trauma narration and processing, so conducting gradual exposure exercises, including those verbal, written, or creative recounting of the abusive events and processing inaccurate and or unhelpful thoughts about that specific abuse or trauma. I stands for in vivo exposure, so gradual exposure to trauma reminders in the child's environment, like darkness or the setting where the trauma occurred, so that the child learns to control their own emotional reactions. C stands for conjoint parent-child sessions, so family work to enhance communication and create opportunities for therapeutic discussion regarding the abuse and for the child to share their trauma narration. And then E stands for enhancing personal safety and future growth, and education and training on personal safety skills, interpersonal relationships, and healthy sexuality, and encouragement in the use of these new skills and in managing future stressors and reminders of the trauma. So in a way, Tf-Cbt is sort of a family-based, developmentally appropriate exposure type approach to treating trauma. Trauma-focused CBT probably has more evidence for its effectiveness in helping children who are survivors of trauma than any other treatment. Children participating in Tf-Cbt show a wide range of improvements, including decreases in PTSD symptomology, depression, anxiety, behavior problems, shame, cognitive distortions, and relationship difficulties. And research also demonstrates a positive treatment response for parents. So parents experience reductions in their own emotional distress and their own depressive symptoms, as well as improvement in how they can support their children and manage their children's behavioral difficulties. So, for example, in one multi-site study, Tf-Cbt was found to be more effective than child-centered play therapy for the treatment of children who had been sexually abused. A randomized controlled trial of skills training in affect and interpersonal regulation, STARE for short, followed by exposure, found that the STARE and exposure condition is more effective than a control group of supportive counseling, followed by exposure, or a control group of skills training, followed by supportive counseling. So the method and the chronology matters. And it's important to note here, though, when we're talking about evidence-based practices, that it's a whole lot easier to show the efficacy of a treatment modality that's manualized. You've got to be able to show that you followed the exact protocol and that the client improved. So some of the methods that you've learned about and that you're going to be learning about are a lot more difficult to manualize than something like Tf-Cbt. They could be just as effective, if not more so, but that becomes a lot more difficult to prove when the treatment isn't perfectly following some manualized protocol. I want to thank you for your attention to this presentation on Tf-Cbt.